Moving on to our first speaker, it's a great pleasure for me personally to welcome Richard Greenwood to Liverpool and to this conference. Dr. Greenwood was my boss some years ago when I was a registrar at Barts, so shares some responsibility for my professional shortcomings. Dr. Greenwood has a long and distinguished career in neurology and neurological rehabilitation. He's been a great advocate for neurological rehabilitation, both in hospital and community settings, and has also contributed to research in the field. And so it's a great pleasure to welcome you, Richard, to speak to us about how knowledge of brain mechanisms drives the delivery of effective rehabilitation. Thank you.
Well, Nick, thank you very much for that introduction. It's a pleasure to see you again and your colleagues, and to see your beautiful new centre, which is almost American in its dimensions. Rehabilitation units with lots of space are clinically effective in reducing behaviour problems, even in the staff. So I'm sure you'll see Peter and Nick relax in the next few years. Stop shouting at people. This is a talk about neurological aspects of rehabilitation after brain injury. And basically it's a plug for involving neurologists in these patients' rehabilitation, down to the clinical reasoning that goes on day to day in their management. And I'm very conscious that in the shape of Nick Fletcher, I may be talking to a future president of our Association of British Neurologists, so I'm sure he'll understand that his task of facilitating rehabilitation is not over until he is in a more effective position to encourage neurologists' involvement. Neurologists have been interested in head injury for a very long time. I'm sure much longer than this slide tries to illustrate. And as has been mentioned, head injury has come to the fore recently with war, as it always does. You've just got to think of Stoke Mandeville after the Second World War. And there's war on the pitch, and war on the streets as well. So there's lots of head injury being identified, and people should become gradually aware that it costs approximately the same as stroke in terms of the national budget. To understand TBI, one needs a few new definitions, or definitions that are new to some people, to distinguish acquired brain injury from TBI, to understand that the early measures of injury severity are looking at arousal, awareness and cognitive function rather than physical function, so it's unlike stroke. To understand that measures that, metrics that rate injury as severe acutely may result in good outcomes long term, which at first sight it is confusing and perhaps a weakness of the measures that are used to rate input and output function in these patients, and perhaps to further develop some of these metrics. One needs an understanding of this tool to think about the patient sitting in front of you and what their health condition is. Is it a disease? Is head injury a disease? Which it probably is, because it generates various neuropathological mechanisms to deteriorate the brain. And how does one achieve good quality of life in patients who are unable to initiate things for themselves. That's often forgotten in patients who are leaving hospital. You see them in the clinic once and pat them on the head, and that's that. And these are the ones that, quote unquote, fall through the net, and they still fall through the net in London, and I'm sure they do in Liverpool. Interestingly, Liverpool has one of the highest incidences of TBI. And if you look at this paper by Alan Tennant, you can see that the Liverpool tops the polls compared with Brent and Harrow, well, compared with London, with 419 per 100,000 patients registered in 2001 and 2, and approximately the same the following year. This is interestingly attributed to low use of public transport at work and a high unemployment rate in younger people of working age. So this is a very timely unit, obviously. Not many people realize that 1 to 2% of the population have sustained a traumatic brain injury with loss of consciousness. It is common. So common, in fact, that the Chinese Minister of Health in about 2008 was heard to say that TBI was the biggest threat to their health economies because motor car and cycle use was increasing, but their safety infrastructure wasn't. So it presents health systems with major problems if they're to manage these patients properly. There's a high prevalence in people who are homeless and in the prison population. Up to 60% in prison, people in prison have had TBI, not necessarily as the cause of their imprisonment, but incidental to their care pathway. And only a small number of patients get to the neurosurgeons, compared with the 80% of admissions who have had mild TBI. Nevertheless, these patients probably have a reduced life expectancy, particularly if they've had problems premorbidly, and particularly if they've had complicated mild TBI. That's to say, imaging changes acutely. This is the latest mortality data from Glasgow, followed up since 1995. This red line shows the TBI cohort. This is other injuries, and this is normal mortality data. The reason for this increased mortality is not known. It may be because they all fall through the net and they don't get any rehab. It may be, which is quite interesting, that they sit around and get fat and develop the metabolic syndrome. And that's given some credence because the causes of death are normal causes of death. They're not skewed to suicide or falls. Or there may be other more covert causes for increased mortality, or any of these. But nevertheless, even people with, and one thing one doesn't know is whether their cohort of MTBI were complicated, whether the ones that die young are complicated MTBI or just TBI. So there's interesting data in the background when one's talking to patients to remember. And this is another way of looking at the data, that people followed up between 5 and 7 and 12 and 14 years deteriorate at these sorts of rates. So even good recovery at 5 to 7 years dies. One can imagine why, if one follows patients up for 10 years, as is possible sometimes, to see that substance abuse and cognitive difficulties drive these patients downhill. And this is what happens if people don't get rehab. acutely early rehab. Just as in 1917, so in 2015, motor recovery of the production of a hemiplegia does not result if the animal is left to his own devices, and this management or lack of management is unnecessary to remark is what is given to most human paralytic cases. This is a patient 1988, a long time ago, but you can see lots of avoidable, preventable deficit. And this is really the strap line that should be above all rehabilitation delivery systems. Avoid preventable deficit. This results in the most significant gains. This patient's locked in by heterotopic ossification, spastic contractures. He hasn't got a peg in. He can't use his hands, which move, although the fingers move, until he's had operations. He's completely bedbound. And with a lengthy period of rehabilitation, which would have been probably shorter had he been admitted to a rehab unit sooner, he eventually got home after 3 years. So if you can avoid preventable deficit, then you can begin to look at plasticity and neural restoration as well as reorganization. But in clinical terms, plasticity is a very, very useful concept, but it's very difficult to know whether what you're doing is generating plasticity or just avoiding preventable deficit in order for plasticity to occur, because you're giving the patient an enriched environment, quote unquote. This is a diagram that we all sit and fiddle around with, but it does try to emphasize that different modules in this sort of network, just like the brain, these service networks need different modules which are used appropriately and are not necessarily led by doctors, because there are a lot of very capable other disciplines out there who can help. Clinical case management of one sort or another, and this is clinical case management, not organizational case management or neuronavigation, is useful in some very complex patients. And so here's the sort of enriched environment one's trying to generate, just like the rats do well in enriched environments with progressive exercise training and reaching. So patients do well in these sorts of environments if they're delivered and organized properly. And apart from anything else, as I mentioned, these places need ring-fence geographies, as you have here so successfully generated. These are generic, largely systemic complications, which I won't detail, and these are more specific complications specific to brain injury that one comes across acutely, early and late in rehabilitation. They all need experience in during one's clinical interaction with patients to know whether what you're seeing is relevant, how it affects prognosis, can you get it early. All these things contribute to proactive medicine rather than reactive medicine and enable patients to optimize outcome as far as possible. It's difficult to see how you can deliver rehabilitation to these sort of patients without an intimate knowledge of the brain and how it works in health and disease. This is an early description of what happens after patients come out of ITU into acute rehabilitation. They're in PTA, and this brilliantly describes this fascinating phenomenon of people coming out of PTA. So in May the 19th, 1931, he was like a man who was intoxicated, paid little or no attention to what was said to him, would not listen to reason. And then on May the 25th, he was quite changed. He remembered being troublesome in the ward, was now very apologetic. He said he felt very well and strong enough to start work again. Every time I see that sort of thing, I find it extraordinary. Not least because nobody quite knows what's going on, why it happens, and hopefully advanced imaging will tell us. But these patients are obviously very difficult to image because they're agitated without giving them a general anaesthetic, which is seldom ethical. It is important to remember that PTA, people come out of PTA sometimes a very long time post-injury, 6-9 months, and at that time their behaviour changes, their prognosis slightly changes as well. This is agitated PTA. And so that's somebody coming out of PTA at 3 months. And because she had 3 months PTA, she had significant residual cognitive deficits and couldn't get back, tried to get back to work, couldn't, and eventually married because she had such good social support to somebody with who also had some cognitive difficulties. But as an example of a continuous effective care pathway with adjustment late on, it was a lesson for everybody. Post-traumatic amnesia is a bit of a misnomer. It's much like delirium. The psychiatrists and neurologists and people who deal with brain injury need to talk about why it's not or why it is, and join it up a bit. Agitation resolves before PTA ends, as we all know. And the agitation may increase when people are tired. So largely it's managed with environmental adjustments, not with drugs. Use the drugs to reduce hypervigilance rather than produce sedation. PTA can also be used as a rather crude, it has to be said, framework, but still a framework to predict outcome long term. So when people come out of PTA and stop rushing about and absconding and start talking to you, everybody gets very excited, but they have forgotten that this person has been a month in PTA or 3 months in PTA, and they will have, inevitably, they will have residual cognitive difficulties, which impact on their future. In functional terms, they tend to impact less if in people who are very high functioning beforehand. One has to use this data in a judicious way. But if you have 10 days of real PTA rather than PTA that's confounded by drugs, you will have some difficulties when you get back to work. For example, you won't be able to burn the candle at both ends and do a full-time job. If you've had a PTA for a month, you probably won't be able to get back to precisely your old job, but you may be able to work in a different role. If you had PTA for 3 months, then you're probably not going to get back to regular paid work, but you may achieve community independence. And it's so, whether or not these people agree with the actual levels of outcome that I'm talking about is to some extent irrelevant. One can develop one's own. But the point is that you need some knowledge of the ceiling that patients can achieve so that you can tell them the envelope within which they can strive to achieve new goals. So you don't say, you will not walk, you will only do this. You say, well, you're not going to get back to full-time work, but you can do all sorts of things in between. And that feeds into goal setting and gives patients optimistic attitudes to the future and their families. So it is this sort of framework is worthwhile in patient management because it enables one to interact with the patient and the family in realistic ways and give them a framework for the future. There are all sorts of neurophysical consequences of severe TBI. I think that hydrocephalus is the one that people tend to forget about, especially 2 or 3 months down the line. People forget that the patient has stalled because they've got hydrocephalus. What one does about it is another matter. Epilepsy, bearing in mind very much that we're at a centre of epilepsy excellence. Since the for 30 years there have been no really good trials of anticonvulsants for post-traumatic epilepsy, and one is due, maybe one is ongoing, I don't know, but it is something that one has to react to rather than treat proactively. And it is a problem in some patients. Beware of post-traumatic non-epileptic attack disorder after mild TBI especially, sometimes triggered off by vertigo. Post-traumatic hypothalamic pituitary axis dysfunction is another chestnut. Shortly there will be some guidelines coming out from a working group. It tends to try to address who to test, when to test people, how to test them, and why to treat them. And you need an endocrinologist to interpret all the numbers, or I do anyway. Who to test? Well, people with severe injuries tend to have are more likely to have problems. When to test? Don't test them too early. How to test? You need an endocrinologist and a compliant laboratory to get the right answer, and why to treat. The problem being that growth hormone deficiency results in very similar symptoms to post-concussional symptoms, and the latter are sometimes treated in mistake for the former, causing the problems. This is an area that is evolving, but at the end of the day, overall, it's an unusual problem. We did have a patient, I always remember, who rang up the secretary 2 or 3 months after discharge to say that he'd lost his penis, and this was because he got so fat because of his hypopituitarism, and he found it again with pituitary replacement. I'll never forget the secretary running down the corridor to tell me. Sometimes one has a suspicion that one of the main things that early post-traumatic hypothalamic pituitary axis dysfunction points to is hypothalamic damage, and that some of the symptoms one's seeing, some of which are listed here, are the result of hypothalamic damage. This is an area that is not really looked into, but is potentially a very interesting one. Please do early cranioplasties. Syndrome of the Trevine wasn't really recognized until about 5 years ago. There's very little, there's no trial data on it, early versus late, as far as I can see. But one only has to see a patient lying in bed, talking to you, and then sitting up and not talking to you, with a huge great cavity in the side of his head, which enlarges as you watch, to know that it is a real issue in some patients. This is not a TBI, this is an intracerebral hemorrhage, but this patient, for example, woke up when the plate was put in very late. So surgeons who say that they're just cosmetic are surgeons who say that they're just cosmetic. This is another group of patients, low-end estate patients, who need more or less specific management. Sometimes in America, everybody goes on amantadine and everybody gets tested with zolpidem, and sometimes that happens here, but you need a stable patient, and don't be surprised if the amantadine causes fits. One doesn't need all the contractures these patients get, and one does need to diagnose them properly, and it's very difficult in some patients, particularly if they are blind, because you can't use visual following as an index of responsiveness, and if they're blind and deaf, it becomes extremely difficult. Exactly how advanced imaging will help that problem remains to be seen, but it has yielded some fascinating data, and this is one bit of that data. This is a patient with severe TBI, grade 3 traumatic axonal injury. Here's the dorsal midbrain hemorrhagic infarct, which you can see here in the pathological specimen. And you can see that the projections from the midbrain mesencephalon to the thalamus and basal forebrain, that's shown in a normal, in red, is very disrupted. And that's probably why this patient is unconscious, because the hemispheric networks are pretty good compared with the control. So this speaks to the idea of TBI being a multifocal syndrome rather than a globally diffuse injury, which is much more true of hypoxic ischemic brain injury, and gives some insight into why hypoxic ischemic brain injuries have a worse prognosis if they're unconscious for a week or two than TBI does. You've only got to get a little bit of recovery for this pathway from the brainstem to the thalamus to fire the hemispheric networks and for the patient to wake up. So DAI is maybe more correctly termed multifocal traumatic axonal injury. These patients are difficult to move on. They have all sorts of social problems. If you move them on, then they do better. Here's a Norwegian study worth reading, Journal of Neurotrauma. They stay shorter time in hospital, 88 versus 123 days, if they're treated seamlessly between acute, early, and later rehab, and they do better, rated by the Glasgow Outcome Scale Extended and the DRS. Once patients get out of hospital, they're walking wounded, and their cognitive difficulties result in repeated failure to cope with the unexpected and leads to anxiety, low mood, depression, catastrophizing anxiety, and ritualized behaviors, just like I'm sure the committee who built this place behaved for a long time until they had opened it. I can recommend this model in one's day-to-day dealing with the outside world. It is important because, in clinical terms, because one immediately fixes into the patient's reality and begins to be able to help them adjust rather than discharge them because they're slightly irritating. Advanced imaging may give progressive insight into the extent, how extensive the axonal injury in these patients and how it damages how it disrupts the functional connectivity between brain networks. Here's the salience network, and here's the default mode network. And if this tract in the salience network is damaged, then the default mode network is not inhibited with a sudden command. The patient doesn't concentrate because the default mode network is still switched on, and they don't react to a sudden request or interaction, and they become anxious and catastrophize. So this is behavior in the scanner, telling us why people behave in the community like they do. Whether cognitive rehabilitation can be optimized with training, non-invasive brain stimulation and drugs remains to be seen. There's been very little work. There has been some work looking at functional outcomes and showing that community goal-focused multidisciplinary programs do work. They probably also work in functional disorders following TBI. And when you're dealing with these people, find out what their PTA is. If they haven't had a PTA of any sort, or if they deteriorate late following injury. Here's somebody who's very articulate when followed up initially, but then became aggressive, and interestingly had had 2 previous compensation claims, mistaken this 3rd time for degenerative neurological disease. Ways of rehabilitating these patients are becoming more recognized, and I'm sure will result in the development of some services in due course. So I think there's material there for neurologists to focus on. There is a TBI module for SBR training now in London at the National. We need a post-CCT neuro-rehab fellowship. I'm hoping you're writing this down, Nick. Consultant credentialing in neuro-rehab is being developed. And there needs to be an option to lead level 1 units as one of a multidisciplinary consultant group. These units will be interesting places to work for multidisciplinary consultant groups, including neurologists, rehab medicine doctors, stroke doctors, and others. And neurologists, I hope you can see, can contribute to patient outcomes and clinical reasoning at the bedside. As long as the neurologists adopt a biopsychosocial model of illness, which Dr. Wade knows much more about than I do, you can grasp the nettle of the patient as a person, which is what neurologists always find very difficult, rather than merely the vehicle of disease. Thank you very much for listening.